Okay, so I was really tired when I made that first video, and I noticed that at the end I said metastasis is kind of like the same thing as benign. I really don't know what I was on, but it's not, okay? In metastasis, you see the cell spreading to very distant sites in the body. So you can get cancer in your lungs, and then, it goes through the blood or the lymph, and then it shoots up into your brain, or it shoots down into your liver. That is what metastasis is. You will not see metastasis with benign cells, because benign cells mind their own business. They don't go around causing trouble, stealing blood supply and oxygen and nutrients, right? That is something you only see with malignant, oh, that is so thick, with malignant cells, okay? Just keep that at the back of your mind. Like, I don't know what I was on yesterday. I was really tired. Okay, so let's move on to the nomenclature, which is really just fancy for how do you name them. And so I have here written benign tumors, but I feel like this applies to everything, because when I tried looking up how to name a malignant tumor, it didn't give me anything useful. Like, it literally just said the same thing. So I'm like, I don't know what's wrong with some people, but okay. So, okay, how do you name a tumor? Well, that's really easy. You have the prefix, which is where it's coming from, and the suffix, which is usually oma, right? So lipoma is abnormal growth of fat tissue, okay? Carcinoma is abnormal growth. Oh, here, let me highlight it as I talk so it's easy to follow along. Is abnormal growth of epithelial cells. And I feel like it should have been called epithelioma, but that doesn't sound as good, And then lymphoma is abnormal growth of lymphatic tissue. See where I'm going with this? Like, it's literally, it's very easy as long as you're up to date with your anatomical terminology and whatnot. Like, it should be very easy for you to stick on. So leukemia is actually, it's kind of different. And again, to every rule, there's always an exception. Okay, there's always somebody trying to be different. So emia means blood. Luke, I guess it means white blood cell. Oh, that's not. Okay. I guess it means like white blood cell. So this is like white blood cells in the blood. Like, that doesn't really make any sense. But just remember that leukemia is abnormal growth of your blood cells. So this could be your red blood cells, white blood cells, platelets. That's all I can think of. I guess proteins. Proteins aren't cells; they're chemicals. I don't know. Okay, so that's basically how you name them. Right, now let's move on to some more interesting concepts, such as carcinoma in situ. So this is literally just a fancy way of saying an early stage cancer. This is when you catch cancer before it actually becomes cancer. Like right before, or actually, it's more accurate to say it's when you catch cancer before it does anything wrong. So it's already cancer, like it's already become a cancer, but it hasn't done anything cancerous yet. Okay, so let's look at like the clinical definition. Carcinomas in situ are pre-invasive epithelial tumors of squamous cell origin. They have not, see how not is highlighted? They have not broken through the basement membrane or invaded the surrounding area. They could end up remaining stable or progressing to invasive or metastatic cancers or regress and disappear. So something I didn't mention in my previous video is that if a cancer or a cell can start out as benign, okay, they can start out as benign and then eventually they can become malignant. Okay, so just because a cancer is usually, or you see a cell, I keep saying cancer, you see a tumor that's benign, sometimes it can turn into cancer. And there's different methods that you can check if a benign tumor is likely to turn into a cancer or not. But we're going to go into that later in the lecture or later in the video. So just keep that at the back of your mind. So a carcinoma in situ is when you find pre-invasive epithelial tumors. So I guess they're benign at this point. I want to say, but I could be wrong. So make sure you search that up later. But the key thing about carcinoma in situ is that they have not broken through the basement membrane. And in the video I made about, this is like way back, it feels like a blast from the past, even though it was like 2 weeks ago. But the video I made about cell adaptation, I spoke about something called hyperplasia. And the thing with hyperplasia is that it does not become, like, it's reversible. It does not become cancer until it hits, oh, sorry, not hyperplasia. I'm thinking of the wrong thing. I meant to say dysplasia. LOL. Okay, so the thing about dysplasia is that it is very, very close to cancer, okay? But it is not yet cancer. Because remember what dysplasia is. It's when you have a normal cell turning into all types of cells, right? So you can get a circle cell, that's the base cell, that's your normal cell, and it starts differentiating into square cells, rectangle cells, triangle cells, pentagon cells, rhomboid cells, okay? So dysplasia is basically due to stress. There is no physiological example of dysplasia because it only happens when your body is undergoing a disease process or some sort of disease process. Something that's not supposed to be happening is happening. And so your cells start to displace, which is just me saying dysplasia. So your cells start to undergo dysplasia to kind of combat this. And that's pretty much what carcinoma in situ is. It's a late stage form of dysplasia where these abnormally growing cells have now hit basement membrane. Okay, so think about it this way. Say this is your lung, right? Okay, and I take like a piece of this lung and I magnify it. So this is, okay, what color did I use? Okay, no, it's not too pink. Here you go. Okay, so that's this piece of the lung, right? And so these are your cells on there. Make them green. So what kind of cells are in the lungs? Well, I think it's stratified columnar epithelial cells or something because they need to filter air and mucus and whatnot. So say you start smoking, right? All that smoke and the gunk from the smoke is going to damage these cells right here. And that's going to cause them to undergo metaplasia first and then dysplasia. Or they could just skip metaplasia and go straight to dysplasia. It's just like a free-for-all. Nobody really knows what happens. And each person's body is different. But when it undergoes dysplasia, these green cells start turning into blue cells. They start turning into purple cells. They start turning into pink cells. They are doing everything they can to adapt to this new smoking environment. But it's not cancer yet, okay? If this person were to stop smoking and get their shit together, these cells will eventually revert back to their, oh my God, that is a big chunk that I just took off. They will eventually revert back to their original position, which is normal green cells, okay? But say this person doesn't stop smoking and these cells keep okay, and if you remember how I said, where is it? Oh, here you go. Anaplasia and pleomorphism. Okay, or pleomorphic. And that's basically what happens here. These cells become anaplastic and pleomorphic. Anaplastic because you can very much tell them apart from the original cells. Like, look, this is green, that's blue. Okay, it's basic. You can tell them apart. Pleomorphism means that it's not just blue. There's light blue. There's, I already used pink. There's yellow. There's purple. Okay, so that's like, these are these concepts being applied in real time so you can really get a good grasp of what I'm trying to say. So at this point, at this point, this is dysplasia, okay? Once, once it, like if these like dividing cells, if they somehow make their way to the basement membrane, which is this guy over here, if these cells somehow find their way over here, then it's game over. Then it becomes cancer, right? Because now they're at the bottom, they're at the root, the source of growth. So all cells going forward will then have this anaplastic and pleomorphic ring to them. They're going to be different. So all cells growing outwards from then on, once the cell hits that basement membrane, is going to be cancer, right? Because you're going to have these rapidly reproducing cells that are not where they're supposed to be. They don't belong in the lungs, okay? So in an early stage, okay, so again, carcinoma in situ is practically a late stage form of dysplasia, okay? They have not yet broken through the basement membrane, so they are not yet deadly cancerous, okay? That's the key, is like the basement membrane, all right? Remember that. So if the cell doesn't hit this basement membrane, right? So if this doesn't happen yet, if it's still on the outside, it is possible for A, it's going to stay there. Like it's not going to get any bigger, it's not going to get any smaller. It remains stable. B, it could hit the basement membrane and then become cancerous, right? And then it's going to get worse because you really can't, like once it hits the basement membrane, it doesn't really get better from there, except you get like therapy. And by therapy, I mean chemotherapy, not like talking about your feelings. Or say this person turned their life around, these cells could disappear. Yeah, and everything could be all dandy and back to normal, okay? If those cells that I just erased, if they hit this basement membrane, it is game over. It is cancer. It is cancer that is going to start rapidly reproducing and doing everything that cancer does, okay? That's just what you need to know. I actually have it written here. So first the cells start off as normal, then they start doing something they shouldn't do, which is dividing into, that's becoming anaplastic and pleomorphic, okay? Then we have dysplasia. Then in dysplasia, the cells start undergoing adaptation, right? So they start developing all these things that make them cancerous. But again, they have not yet hit the full thickness of the epithelium and it's reversible. In carcinoma in situ, right, we have a full thickness. So it's like a more severe form of dysplasia. If in dysplasia you only had like 2 layers of cells that had changed, in carcinoma in situ, you're going to see like 6 layers, 10 layers of cells, okay? But the key thing is that they have not hit the basement membrane. And once they do hit the basement membrane, that's when you get your invasive cancer, all right? So let's talk about the stages of cancer development. How does it start? How does it end? We start off with tumor initiation. And like I said, I'm really going to be saying the same thing over and over again because cancer is just one concept presented to you in many different ways. Tumor initiation is when a normal cell becomes a cancer cell. Now, there's a lot of reasons this could happen. The biggest one is going to be your epigenetics, your environment, what you eat, what you drink, how you live, okay? Those types of things will affect your cell development. And that could lead to the development of a cancer cell. That is tumor initiation, okay? So the cell has just been born. It doesn't know who he is. He doesn't know what he wants to do with himself. He just came into the world and he's confused, okay? That's tumor initiation. Then we have tumor promotion, okay? This is when the cancer cell becomes more complex. So it starts having genetic mutations, it starts clonal expansion, and then it starts proliferating. Okay, so now the cancer cell has kind of realized that, oh, I'm a cancer cell. I don't have to do what the other cells do. I can do whatever I want, right? But it hasn't set in, but it's starting to set in. Okay, so it's starting to realize that he can do whatever he wants. And so he's going to start preparing to do whatever he wants, right? Genetic mutation. These genes are going to start mutating. Clonal expansion. He's going to make more of himself that have these mutated genes. And proliferating, which is reproduction. The thing about it is that in tumor promotion, it is reversible. If you stop smoking or stop drinking or start living healthy or stop working at that radioactive chemical plant that you decided to work at for some reason, this could go back to normal. You could go back to being a normal blue cell. It is reversible. Then we have tumor progression. Again, this is the most dangerous stage of cancer, or rather the most dangerous stage of cancer development, because the cell has fully stepped into his cancer role. He realizes that he can do whatever he wants. And guess what he's going to do? He's going to do whatever he wants. He's going to start becoming invasive. Okay, he's going to start rapidly reproducing. Okay, because cancer is rapidly reproducing cells, and he's often reliant on the environment. So hold this thought, this one, because it's going to come into play later, like maybe way later, but that's just something you need to know. Initiation, the cell has just been born. A random cell didn't divide properly, and he divided into a cancer cell. This cancer cell has just been created. It's been initiated. Promotion means that it starts getting all these crazy upgrades. We see genetic mutation, we see clonal expansion, we see proliferation. Promotion is reversible. If you get a promotion at your job and you mess up, they can take that promotion away. It is reversible. Progression, there's nothing you can do at this point. I mean, there's a few things you can do, but there's nothing like the body can do. There's things that you can do in the world of medicine and science and whatnot, but body-wise, the cancer is growing. The cancer is becoming invasive and it's becoming metastatic. So let's talk about factors affecting human carcinogens. All right, and this is like big people language for how do cells become cancerous? Like, yeah, I said in tumor promotion, I said that the cell starts getting upgrades. What are these upgrades? Okay, like what is happening? And that's what we're about to talk about right now. So the first thing we have that's a key point of cancer promotion is the activation of your proto-oncogenes. Now, proto-oncogenes are good genes. They tell the cells of your body rather, to start dividing, to start growing. You need this, right? If you get a cut on your hand or like a bruise or a scrape on your hand, the proto-oncogenes will tell your skin cells to start rapidly dividing so that they can heal that hand. Okay? If you lose blood cells, your proto-oncogenes are going to tell your blood cells to start rapidly dividing, and you're going to have more blood. Okay? Proto-oncogenes are normal genes. If you hear proto-oncogene, it is not bad, it is good. So the science book definition is normal genes which regulate the proliferation of cells and promotes their growth. They are the lock that keeps cells from becoming cancerous. Okay? A proto-oncogene will tell you when to grow. All right? It's like the gas pedal of your body's development. And if you overexpress a proto-oncogene, it will lead to becoming an oncogene. Okay? So that's why activation of proto-oncogenes is like the first step or one of the main steps of cancer progression or tumor progression rather, right? Because if you overexpress a proto-oncogene, it becomes an oncogene. An oncogene are gene products related to growth. So if proto-oncogenes are like the gas pedal of your development, they tell the cells when to divide. Oncogenes is like that gas pedal being stuck to the floor, okay? So it is constantly dividing and it's constantly speeding, it's rapidly dividing, and this actually ties into the next factor. Because usually if you're stuck in a car, right, and you notice that your gas pedal is stuck to the floor, what's the next thing you're gonna do? You're gonna try and hit the brakes, right? You're going to try and say, oh my God, this car is driving really fast. And if I don't do something, I'm going to die. Your next option, or at least what most normal people would do, is they would try to hit the brakes. But in cancer, these brakes have failed, okay? And that leads us into the next step of cancer, which is gene mutation. So in gene mutation, we see the loss or the inactivity of our tumor suppressor genes. And tumor suppressor genes are like the brakes of development. So your proto-oncogenes will tell your cells, hey, it's time for you to start growing. Okay, we need more of you guys. Your tumor suppressor genes will say, okay, guys, you've grown enough. It's time to stop. Another name for your tumor suppressor gene is your anti-oncogene. Okay, and I have it here in a little box blob. Tumor suppressor genes are gene products that would normally inhibit growth. Okay, so they would tell the cells like, hey, you've grown enough. Time to stop. In cancer, what you see is that these cells have been inactivated or they have been completely destroyed, or rather these genes have been inactivated or unexpressed. So back to our car analogy, right? So your gas pedal is stuck to the floor and your brakes have failed. So you're just going to keep going. There's nothing stopping you from dividing, okay? And a good example of a tumor suppressor gene is the BRCA1 and the BRCA2. I think it's seen in instances where your tumor suppressor genes, these guys specifically, are inactivated. I think that's when you have a high chance of developing breast cancer. I could be wrong though, so do your research. Okay, and then the third one is still another type of gene mutation, which results to the overexpression of products that can prevent normal cell death or apoptosis, which is fancy for saying the cells don't die. So if I were to relate this to the car analogy, right? So say you notice that this car, its gas pedal is stuck to the floor, which is the activation of oncogenes. The brakes have failed, which is the inactivation of tumor suppressor genes. What are you going to do with a car like this? You're going to destroy it, right? Because you don't want any other person getting in this car and, dying from a car crash because they don't have brakes and their gas pedal is stuck to the floor. You're going to try and destroy this car. So usually, if a cell has oncogenes and it has no tumor suppressor genes, your body is going to tell the cell to undergo apoptosis. Okay? And apoptosis is cell suicide. So in cancer, you have the cancer producing things that help it, that prevent it from undergoing apoptosis. So the body can't even tell this cancerous cell to kill itself. And so these are the three main hallmarks or the three main factors affecting human carcinogens, which is the three main things that contribute to cancer development. Number one, your gas pedal gets stuck. You have activated oncogenes. They tell the cell to just keep growing, just keep growing, just keep growing, just keep growing. Number two, gene mutation. These tumor suppressor genes have been shut off. For some reason, either they were completely deleted or they were inactivated. For some reason, these tumor suppressor genes are not doing their job. So it's keep growing, keep growing, keep growing, keep growing, and there's nothing telling it to stop. Okay? And then, usually, when the body notices that a cell just keeps growing and it doesn't have this tumor suppressor gene, the body will tell that cell to kill itself. In cancer, in all deadly stages of cancer, or in all deadly types of cancer, that process has been X'd out. So there is no apoptosis. That cell is not dying. It just keeps and keeps and keeps growing. Okay? So here's my little summary. Activation of genes that cause cells to divide, suppression of genes which normally inhibit growth, and removal of the ability for a cell to kill itself when it misbehaves. All right? And I want to point out that there are way more than three factors that will lead to cancer development or to cancer progression, but these are like the big three. And I think it's pretty obvious why, so I'm not really going to say much about that anymore because I feel like I spent a lot of time on it. Okay, so something that you need to know, very, very, very important, is that one mutation will not cause cancer. Okay, so say you just have one of this happening. So say the cells have activation of proto-oncogenes. That's the only thing that's happened. That means that your tumor suppressor genes are still going to be working, and your gene mutations, like the cell's still going to be able to kill itself. So obviously that renders this inadequate, right? Because if the cell has like its gas pedal stuck to the floor, but the brakes are still working, you can stop the car. Okay, or say you have activation of proto-oncogenes and gene mutation that leads to the suppression of our tumor suppressor genes. Because you're suppressing the tumor suppressor genes. That's like kind of funny for some reason, but I don't know. Okay, so say you have your gas pedal stuck to the floor and the brakes have failed. You can still destroy the car. You see what I mean? So you need more than just one or two mutations to happen for something to become cancerous, right? So you don't just need one. You need at least 4 to 7. But we're going to get there. We're like literally right there, okay? So now let's talk about our genetic events. And these are things that cause an alteration in the organism's DNA. Okay, so all these things that I just talked about, what could lead to them, right? What are the events that lead up to this genetic mutation? That's what we're about to talk about right now. But before I go into that, you should already know by now, and if you don't, well, you're about to know that cancer is not a genetic disease. Oh, sorry, cancer is a genetic disease. I meant to say cancer is not a contagious disease. My bad, lol. This basically means that if someone has cancer, right, and you hold them, or you hug them, or you kiss them, or you sleep with them, the chances of you getting cancer are very close to none, okay? Except they have like HIV, which is what led to them having cancer, and then you sleep with someone with HIV, then you can get HIV too, and that's like low-key, that's not great at all. But cancer is not contagious, okay? I cannot get cancer from someone else. And it is not random, okay? Or I guess it is random, but like when I say it's not random, I mean it in the sense that it doesn't just happen out of the blue, right? There are these things happening in your body at the genetic level that leads to cancer. Like cancer doesn't just wake up one day and happen, right? There's all these things happening in the background that build up to it. So to you, right, it might appear random. You might just wake up and go to the hospital because you're feeling tired and realize you have cancer. You're gonna be like, oh my God, like this is so random, finding out I have cancer on a random Wednesday afternoon in March, right? But it's not random, right? There's all these things happening in the background. There's all these suppression of your tumor suppressor genes, there's activation of your oncogenes, and there's the loss of the ability to undergo apoptosis. And there's also a bunch of other stuff. Remember, these are just the main three, right? So all these things are happening in the background. Cancer doesn't just wake up one day and happen, okay? Also, it is if your mom develops breast cancer so I said you cannot contact cancer from another person. The only exception to this would be if your parents had some kind of mutation in their gametes, so in the sperm cell and the egg cell. If your parents had a cancerous mutation in their gametes and then they had a baby and that baby was you would have a high chance of developing cancer because this cancer was in the germ cells. It was in it was in the eggs and it was in the sperm. Okay, that is one of the only exceptions to cancer when I say cancer is not contagious. That's like the only way you can contact cancer from someone else. Okay? Okay. Good, I've talked about that, so now you know. All right, so let's talk about some things that can lead to genetic mutation. We have point mutations, deletions, insertions, gene amplifications, and chromosomal rearrangement. I'm gonna explain that later, but yeah, okay? Another thing I wanna point out is that as you grow older, your chances of developing cancer astronomically increase. Not astronomically, significantly increase, okay? And there's a couple reasons for this. Number one, the older you get, right, the easier it is for your cells to make mistakes when dividing. And these mistakes will lead to DNA replication errors. And that can lead to literally any of these things, okay? And when that happens, it's easy for you to get cancer. That's why old people are at a higher risk for cancer. Also, as you grow older, your immune cells aren't as strong and as active as they used to be. So they can't even catch the early stages of cancer that they would have caught when you were 30 or 20 or even 40, okay? Then, the older you are, the more experience you have with carcinogens. And carcinogens are things that cause cancer, or things that can cause cancer. So smoking, sunlight, alcohol, radioactive chemicals, right? The older you get, the more likely you are to have more experience with these carcinogens, which can increase your chances of getting cancer. And one of the main reasons that old people develop cancer is because they have all these mutations that have built up over time, okay? And like I said before, you need multiple hits for cancer to happen. You need 4 to 7. 3 is not enough. So I have an example of a multi-hit theory. So this one has 5 hits, okay? And I say you need 4 to 7. That does not mean that it can only be within 4 and 7, okay? You could have 5 hits, 6 hits, 4 hits, 7 hits. Like, you know what I mean? So 4 to 7, not just 4 and 7, because I kind of confused myself with that a while back, okay? So the first thing for this example, okay, this is not how all cancers happen. Some people can skip steps, some people can add steps. This is just an example for you to understand what I mean. First off, you have your oncogenes activated, okay? So this gas pedal is now stuck to the floor. You're telling the cells to grow, 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 grow. Next, we have your tumor suppressor genes lost. The brakes have been cut. There's nothing telling them to stop. Then we have no apoptosis. The cell cannot kill itself. The cell will not kill itself. It is ignoring all the chemicals sent out by all the other cells telling it to kill itself because it wants to keep growing. And keep growing, it shall. Okay? Then we have our DNA repair system failing. And as the term implies, if this happens, right, if these 3 things happen, which is the 3 things that we talked about before, sometimes the DNA can repair itself, which can lead to everything returning back to normal. Okay, that's what I'm saying. Like, you don't just need 3 things to happen. You need at least 4. All right, but in this case, we have 5, so let's keep going. So the DNA repair system fails. So the cell, the genes, the DNA can't repair itself. So it's stuck the way it is. It's stuck with the oncogenes, it's stuck with no tumor suppressor genes, and it's avoiding apoptosis. And the 5th stage for this example is the triggering of angiogenesis. Now, if you remember, genesis means the beginning, or to create, to generate, basically. Angio means blood vessels. So in this example, once the cell, what percent is my phone on? Okay, I'm at 12 right now. So in this example, angiogenesis, no, not in this example. Angiogenesis is the growth of new blood vessels, period. Okay, angiogenesis will always mean the growth of new blood vessels, not just in this example. So once this cell, or once this cancer, this tumor, starts triggering angiogenesis, it's game over for this example. Okay, why? Because angiogenesis means the generation of blood vessels. What does blood vessels, or what do blood vessels carry? They carry blood. What does blood have? Everything. Okay, it has oxygen, it has nutrients, it has protein, it has platelets, it has literally everything. Okay, and a tumor developing angiogenesis means that this cell now has uncontrolled access to your body's nutrients. So it is going to eat and take and destroy in the process. Okay, it's going to start doing everything that you associate with normal cancer. Okay, and that's the stepwise accumulation of genetic events, of these hits. Okay. So let's talk about a driver versus a passenger mutation. So driver mutations are the things that actually cause cancer. They give the cancer that genetic advantage. So these mutations that I talked about, these main 3, these are examples of your driver mutations. But remember how I said these are just the main 3 and there's more? There's like 140 of them. So there's like way more driver mutations, okay? Passenger mutations are kind of just there for the ride, okay? Like if a cancer cell is rapidly reproducing and they start developing all the things we already talked about. So these 3 things, oncogenes, loss of tumor suppressor genes, loss of apoptosis. If the cell became green, right, that's a mutation, but it doesn't really affect the cell's ability to keep growing, and it doesn't stop the cell's ability to keep growing either. It's just there. So think of it like when you're driving a car, drivers are the person who actually do the driving. Passengers just sit in the passenger seat like a little passenger princess, and yeah, like they're neutral, they're random, they're not stopping the growth, but they're not helping it either. All right. Okay, so now let's talk about those alterations that we had mentioned before. So a point mutation is a small change in DNAs that occurs in one or a few base pairs. So if you remember your DNA, you know it's A to T and G to C. So I know apples to trees and cars to garages. That's how I remember it. Right, so let me just draw some out so I can give an example. What am I doing? Okay. Okay, so say this is your genome, right? In a point mutation, you have a small change to a few base pairs. So say like these 3 over here, right? Something happens. I don't know. Maybe you smoked a little too much coke. Can you even smoke coke? Anyways, maybe you smoked a little too much crack. Okay, you sniffed a little too much coke. Yeah, you can sniff coke. I don't think you can smoke it. And if you are smoking it, then Jesus Christ, what are you doing? Okay? And all of a sudden, this isn't pink anymore. Now it's purple. And this isn't yellow anymore. Now it's red. This is known as a point mutation because it's occurring in this small point of the gene. This small little point of the gene. There's many different things that can cause this to happen. Okay, so maybe the cell's dividing too much, and all of a sudden, this point mutation happens. Most times, point mutations are harmless. Okay, they happen, and if you remember from your anatomy class, there's a lot of different. Oh my god, I'm so tired. But if you remember from your anatomy class, a lot of different combinations can lead to the same thing. Like I'm just gonna give you an example, but I don't really remember. So like UUA, AAU, they all represent the stop. Okay, just you know what I'm talking about. You should know what I'm talking about. So they all represent the stop, right? So even if you have a small random mutation, there's a good chance it'll still represent the same thing, right? That's like one of your body's defense mechanisms for mistakes, right? So it's very rare that a point mutation will lead to any of the genetic events we talked about. So it could lead to activation of oncogenes, it could lead to suppression of tumor suppressor genes, it could lead to loss of apoptosis. But the chances of it happening are really rare. But again, all you need is one. You know what I mean? All you need is one thing to kickstart the process. Okay, so that's what your point mutations. Deletions means there's a part of your gene deleted. So we lose 1, and now it's 3 instead of 4. That's a genetic event. Okay, insertion means a new something is added. So it's supposed to be 4, and then we add 1 more. Why does that rhyme? It's supposed to be 4, and then we add 1 more. Okay, so now we have 5 instead of 4. That's insertion. Deletion means you remove one, insertion means you add one. And then gene amplification is when a small piece of chromosome is duplicated over and over again. So say you have a point mutation, right? That leads to activation of an oncogene, right? Gene amplification is going to take that one oncogene and multiply it over and over again. So now we're overexpressing our oncogenes, which is one of the key hallmarks of cancer, okay? Then we have chromosomal translocation. So that's like when you have one piece of a chromosome transferred to another. I know what this is, so I'm not going to explain it because I'm going to be the main person watching this video. So if you are that interested, you can look it up, but it's not that important, okay? Now let's talk about a tumor microenvironment. So in the slides, it says that tumor or cancer is analogous to wound healing, okay? And it might sound confusing, but think about it. What happens during wound healing? There's 4 stages, or 3 stages, depending on which textbook you use to learn. There's hemostasis, inflammation, proliferation, and the final stage is when, like, you've already set down the fibroblasts, and you're, like, doing the final work. Damn, I can't remember the words. I can explain them, but I can't remember the words. Anyways, that's not really important right now. So basically, in wound healing, what happens? Well, one, you're going to get your neutrophils and your macrophages to the... Actually, I have a good idea. Let's go back to... I think it'd be here. Oof, it's right here. Okay, so we have hemostasis, inflammation, proliferation, and remodeling. Okay, so in hemostasis, this is when your blood vessels constrict, blood is coagulating, increasing platelets, blood clots form, blah, 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 blah. This is the important thing. Okay, so when we learned about the stages of wound healing, we talked about vasodilation and neutrophils and macrophages. So when I made this, I said that the neutrophils and the macrophages are there to do defense and cleanup. The macrophages will focus on the defense. The neutrophils will focus on the defense, and the macrophages will focus on cleanup. Now, in all honesty, when I said that, I was just reading off the textbook. I didn't really understand it, right? Because macrophages are phagocytes. They kill cells. They kill abnormal cells. So it could be bacteria, fungi, virus, whatever. And they are antigen presenting. So their job is literally to eat a part of the problem, of the bacteria, of the cancerous cell, of whatever it is, and to go present it to the helper T cell so that the helper T cell can do its job. I'm not going to recite the whole process of immunity again, because that is like a lot, and that was like a while ago. Okay, so I don't want to do that. But I remember that macrophages are antigen presenting. So when I read that macrophages are the growth factors, I didn't really understand what that meant. Okay, I just kind of said it and just kept it at the back of my head, but I didn't really go into it. And so now we're about to finally understand what I meant when I said macrophages do the growth factors. Okay, so let's go back to the other one so I don't mess up my old notes. Okay, so again, they're analogous to wound healing. So like I said, in wound healing, what's going to happen? You're going to see all this blood flowing to the site to bring in nutrients, to bring in white blood cells, to bring in platelets, to bring in a bunch of stuff, protein, right? Because you want to heal the wound. You want to regenerate new cells so that you can heal the wound, fill, sink, and shrink, or whatever, okay? So in cancer growth, we have, so again, because it's analogous to wound healing, when a cancer starts developing, it recruits T lymphocytes and macrophages. And there's 2 different types of macrophages. We have our M1 macrophages, which are the killers. And these are the macrophages that we talked about in immunity. When we were talking about phagocytosis, antigen presenting, all of that, we were mostly referring to the M1 macrophage. The M2 macrophage, however, is what we're saying, or is what we're referring to when we say that macrophages are they help in growth, right? Because the M2 macrophage, when it comes to the site of the wound, right, it's there to help the wound grow. Okay, so now let's apply that to cancer. When a macrophage, especially when an M2 macrophage comes to the site of the cancer, what's it going to do? It's going to help the cancer grow. Okay, how's it going to do that? It's going to release growth factors, release cytokines, and promote angiogenesis. What is angiogenesis? See, it's coming into play now. What is angiogenesis? Angiogenesis is the generation of new blood cells. And in this example that I gave you, this is the final stage required for something to become cancerous. Okay, now why is angiogenesis the final stage? In this example, why is it the final stage required for something to become cancerous? Because when you develop angiogenesis, you are ultimately giving this cancer cell a big one-way ticket to all-you-can-eat land. Okay, so they have all this access to blood vessels, to your nutrients, and because it's a blood vessel, it's ultimately going to connect with other blood vessels, which will ultimately connect to other places. This is what helps cancer cells metastasize, because they leave through these blood vessels that they've created and they go to other parts of the body. All right? So again, M2s are the growers, M1s are the killers. So I don't really know if I don't really have like a mnemonic for memorizing that. It was just really fascinating to me. So I remember it very easily because I was just really intrigued by it. Okay? So when this macrophage, this M2 comes to that to the cancer cell and it starts doing all these things that it would usually do for a wound, right? Because when you have a wound, you do want to have new blood vessels because your blood vessels are probably going to be ruptured from whatever cut it is that you got or whatever scrape or whatever wound you got. So that's why M2 macrophages do normally promote angiogenesis. Okay? And this actually ties into what I say when if you understand that a concept or a pathway is applied, right? That pathway will always be applied again. It doesn't change randomly. And if it does change randomly and you learn what could cause that kind of random change, that's when pathway really starts to become fun. Okay, so think about it this way. M2 macrophages will always promote angiogenesis. This is why in wounds, your M2 macrophages are responsible for all the healing factors. That's why you have new blood vessels in wounds. In cancers, it's the exact same pathway. If an M2 macrophage arrives at the scene, it will start doing what M2 macrophages do, which is promoting angiogenesis and releasing growth and healing factors, which will only help the cancer grow. So there is no case when an M2 macrophage comes that it will not cause angiogenesis. And if there is a case like that, you should be asking, what type of case is it? Why is it happening? Okay, and so when you understand like the nuances, pathway becomes like this, it opens up into this really, really interesting and unique world of understanding. Okay, that's just me going on a rant, but yeah. So anyways, another thing these M2 macrophages do is that they release cytokines. And what do cytokines do? Most of them are chemotactic factors, right? So they're going to call other things to the site of the cancer, right? So in a wound healing, what would we get? Right? We get fibroblasts. We have immune cells. We have blood vessels. We have fat cells. We have proteins coming from the blood, right? All these things that would usually help in growth, right? They help in growth, right? Now they're going to help promote the growth of the cancer. Okay? And all these things are going to lead to the development of something known as a stroma, which is a cancer environment that promotes the growth of the cancer. That is why in most cancers, in most bad, like really bad cancers, 90% of the time you will see more M2 macrophages than M1 because M2s promote growth. Okay? Okay, there's also a concept known as tumor heterogeneity that I want you to know, which is basically as the cancer keeps dividing, right? Remember, they're like stem cells. They can do whatever they want. They can become whoever they want. As they keep dividing, more mutations are going to happen, right? So you're going to have cells with different types of genes. And think about it. If you have cells with different types of genes, right? So different cells, they are going to respond differently to different stimuli because they're going to have different phenotypes. So you're going to see cells that look very different from each other. They're all the same cancer, right? They're all the same cancer, but they are they're genetically and physically different from each other. So in one tumor, you could have different types of the same type of cell. That is what I mean when I say cancer is like, it's ultimately the biggest fuck you it's like the biggest fuck you to our body, right? But like as time goes on, you'll see what I mean when I say that. So ultimately, what tumor heterogeneity means is that there's genetic diversity in the same tumor. And think about how this applies in medication, right? If you have medication that targets, okay, let me give them different eyes. So this is cell number 1. This is cell number 2. That's cell number 3. No, this is cell number 4. Whatever kills this guy won't kill this guy. Whatever kills this guy won't kill this guy. You see what I mean? So it's very hard to treat heterogeneous tumors because like whatever you can kill off some cells, but you might not kill off others. Okay, so it's hard to treat. Okay, so again, I said cancer was a stem cell. Like I said, I'm gonna really be saying the same thing over and over and over again. It is the way of the world. I don't know what to say. But again, cancer is a stem cell, so they self-renew. They resist treatment. So the body's gonna be like, hey, let me fix you. Let me make you normal again. The cancer's gonna be like, no, get away from me. Fuck you. See what I mean? See what I mean when I say it's like the biggest fuck you the body has? Okay? And then the thing with them is that even after chemotherapy, even after you manage to get rid of most of them, because they are rapidly reproducing, there's always a possibility that it can come back. Okay, because if you even leave one cell in your body, if you leave just one cell, it could reproduce again. And it could start the whole cycle from the very beginning. Okay, that's why that's why cancer is so hard to treat. Okay, because there's all these nuances to it. Right? So let's talk about hallmarks of cancer. And funny story is that when I was like writing this part, I was like, what the fuck is a hallmark? Like, what is a hallmark? I don't know what that means. A hallmark is basically a defining characteristic of something. I don't know why I forgot that for some reason, but I did. I don't know how, but I did. What time is it? Oh, it's almost 8 o'clock. Okay. So the first hallmark of cancer is sustained proliferative signaling. Okay? So a normal cell only grows when it's told to grow. A normal cell only grows when it's told to grow. Your proto-oncogenes will tell the normal cell to grow, and the normal cell's gonna be like, yes, sir. Here, this cell is like, fuck you to the proto-oncogene. It just grows. It doesn't need to be told, like, it doesn't care if you tell it to grow, if you don't tell it to grow. It's gonna grow. It can do whatever it wants, right? So how is this? What's happening here? So how it works is that it can send out constant growth signals that never turns off. So it's just gonna keep growing. It's gonna keep growing. It doesn't grow when it's told to grow. It grows when it wants to grow. And the thing about cancer is that it always wants to grow, okay? A good example of this, and this actually ties into the, that's what I'm saying. Like, I'm literally going to be saying the same thing over and over again, so it should stick. So this is literally activation of proto-oncogenes, which leads to the overactivity of oncogenes, okay? So the cancer just keeps growing, just keeps growing, right? How does it do this? Okay, so I already explained. Okay, a good example of an oncogene is the RAS oncogene. I've been skipping. I haven't really said anything. Like, I've been making notes about it, but I haven't really talked about it. But yeah, it's a RAS oncogene. I think I had given an example of what it does earlier. Here you go. So the RAS gene converts a proto-oncogene to be an oncogene. I just didn't want to talk about it for some reason. Like, I don't know, but okay. Okay, so we have autocrine stimulation. This is the ability of a cancer cell to secrete its own growth factor, or to have growth factor receptors that stimulate its own growth. Usually, how your body tells a cell to grow is that it secretes growth factors. The cell picks up on these chemicals and it's like, okay, time for me to grow, and then it starts growing. Cancer secretes its own growth factors. So cancer will literally tell itself, hey man, I think I should grow. And it's like, yeah, I'm kind of right, and then it starts growing, okay? It doesn't need help from outside to do this. A good example of this is the human epidermal growth factor receptor 2, which is the HER2, okay? Then we have evading growth suppression. This is the second hallmark of cancer. This is where your tumor suppressor genes come into play. So, So your tumor suppressor genes are genes that tell the cancer or the cell to stop growing. So say you have a wound, right, and your epithelial cells start rapidly dividing to, cover the wound or to do whatever. Once the wound healing is complete, your tumor suppressor genes are going to tell your epithelial cells like, hey, it's okay, you've done enough, you can stop growing now, and they're going to stop growing. Okay. And cancer, these tumor suppressor genes are going to be like, hey, stop growing, and cancer's going to be like, no, I don't think so, and it's going to keep growing. It's going to hide from the tumor suppressor genes. It's going to evade growth suppression, right? So it's like, oh, it's over here. And it's like, you'll never find me, and it's like, oh, but where did he go? So these are your BRCA1 and your BRCA2 tumor suppressor genes, and if these genes are mutated, it can lead to breast cancer. Surprise, surprise. I think I mentioned that earlier. So if a person has a mutation in their tumor suppressor genes, their chances of getting cancer increases very, very significantly. What are some other examples of tumor suppressor genes, you might ask? The first one is your P53. You don't need to remember the other ones, or I would recommend you do. But if you want to remember something, remember that your P53 is the main tumor suppressor gene of your body. Okay, a mutation to your P53 is like a one-way ticket to Cancer Town. And surprise, surprise, if you have that mutation, everybody in Cancer Town is gonna know who you are. Okay, because you're gonna be their number one president. Right? Okay. So your P53 is what tells your red blood cells to die after 180 days. I've talked about this before, about red blood cells needing to die every 180 days. I'm not going to talk about it again. Actually, no, I will, because I want to. So your red blood cells carry oxygen, and because oxygen is so important, your body only wants the best cells to carry it. And so because of that, every 180 days, your red blood cells will replace each other, because they want to be in tip-top shape to carry that oxygen to perfuse the rest of your body. Okay? So every 180 days, the P53 gene is going to be like, all right, guys, time to kill yourself. We need newer, fresher faces, okay? Like, you guys had a good one, it's time to go. And the red blood cells are going to be like, oh man, it's for the best of the human body. So they die. Right? In your P53 gene, if this gene stops, your red blood cells are not going to stop, are not going to kill themselves. They're going to keep going. Okay? And this is never going to stop growing. So another example is your RB1 gene, which is retinoblastoma, which can cause retinoblastoma. And remember, oma is rapidly reproducing. Retinoblast is, I guess, your eyes. So your eye cells are going to have cancer of the eye. Okay. Your NF1, a suppression in your NF1 gene will lead to neurofibromatosis, which doesn't end in oma for some reason because everybody wants to be different nowadays. And then we have mutations to your APC tumor suppressor gene, which will lead to polyps, which is commonly seen in Hispanic populations. Why? I don't know. Okay, next we have genomic instability, right? That's the other hallmark of cancer. As the cancer keep dividing, new mutations happen. Cells, like, this is literally that tumor heterogeneity. This is literally that tumor thing I talked about. Okay, so there's genetic diversity in the same tumor that makes the cancer harder to kill. Usually, we have something known as caretaker genes. These genes repair your damaged DNA and they maintain your genomic stability. Why did I say instability? They maintain genomic stability. An example of this is your BRCA1 and your BRCA2. Yes, you are not hallucinating. That is the same BRCA1 and BRCA. Where is it? That is the same BRCA1 and BRCA2 that I talked about. They are both tumor suppressor genes and caretaker genes, okay? That is why a mutation in your BRCA1 and your BRCA2 significantly increases your chances of getting cancer by about 60 to 70%. Like, it's a big increase in your chances of getting cancer, okay? And, okay, so in cancer, we see a loss of heterozygosity, which leads to more mutations, which leads to more diversity. We also see chromosome application, which leads to more aggressive behavior. Again, this is literally the same thing. Chromosome application, I already talked about it. Where is it? Gene application. Well, genes, but now it's chromosome. It's chromosome. They're literally the same thing. Okay, so you see what I'm saying? Like, it's literally me saying the same thing over and over and over again. Okay, and then you have loss of chromosomes, which could be loss of those tumor suppressor genes, right? Okay, that's genomic instability. Okay. Okay, so another thing is the fourth hallmark of cancer is that we enable replication and mortality. The cancer never dies. The cancer lives forever. Our normal cells can only divide a limited number of times. Okay, why? That's because of something known as a telomere. Okay, telomeres are genetic protective cap placed on the end of each chromosome, and they are held in place by something known as a telomerase. Telomerase? I don't know. But I don't know. Yeah, the telomerase is something that holds a telomere. Usually, it's like this. So this is your telomeres. Oh my god, that's huge. This is your telomere. Okay, so the more you divide, the shorter your telomere gets, which is why in old people, right? That's why aging happens, because at some point your cells lose the telomeres, and because of this, their cells are unable to regenerate. So we don't see, like, that's why in young people are less likely to get sick. They're healthier. Their skin is better because they have a lot of telomere. In old people, this telomere is gone. Okay, so they're not able to reproduce new cells. They're stuck with the old cells that they have. That's why old people are more likely to get sick. They get tired so easily. They're more fragile because their cells are old. Okay. And the thing is, I think telomeres have like a lifespan of, I think, max 120 years, which is why some people think it to be 120. Also, when you hear people saying things like, oh, my genetic age is 30, even though I'm 60, they're referring to their telomere growth. So I guess there's like, although those ads are usually fake and not to be trusted, like, at all, okay, but there is like some truth to that, right? If you measure a person's telomere growth, you can tell how old they are genetically, right? Because as you grow older, you have shorter telomeres. So if an old person has long telomeres, that means their cells are still reproducing. That's why some older people look better than others because of their genetic age or whatever. But yeah, that's just like me going on a tangent. So, okay, I've already explained how this works in a normal cell. So in cancer, these cells are able to sustain telomeres on the cancer cell chromosome through telomerase. Okay, so what does that mean? It means your telomeres don't get shorter, which means the cell is going to be able to keep dividing. Okay, and in 90% of cancers, you're going to see sustained telomere growth. Okay. Oh, okay, and here's this. You can pause it and read it if you want. It's literally what I said, but it's said in a much more concise way. So number 5, cellular adaptations. We have angiogenesis. Angiogenesis is the ability of a cancer cell to create its own blood supply. It's also called neovascularization. Again, neo means new, vascular means vessels, new vessels. Okay. I don't know why we have so many different ways of saying the same thing. Angiogenesis, like, these are literally the same thing. Who's coming up with these names, bro? But anyways, okay. So this angiogenesis is like really bad. Like once a cancer starts or gains the ability to perform angiogenesis, it's kind of, you're low-key kind of cooked for a couple of reasons. Okay, let's go over it. Because number one, when it creates this blood vessel, the blood vessels that it creates are low-key ass. Okay, like it's straight up booty cheeks because one, it's never created a blood vessel before. It's not like our body who's been doing this since we were born, right? So the blood vessels that it creates are fragile. They're very porous, right? Which is why cancer patients are more likely to bleed because these blood vessels that the cancer is creating are so weak. They are very, very weak. So a patient coughs, that blood vessel is going to rupture. The patient's going to start hemorrhaging. That is because the blood vessels that it created are straight up chewed. Okay, they're not good. All right. But the thing about that is because these blood vessels are porous, it allows the cancer to easily leave the vessel and leak into other places. This is where we start getting metastasis. Okay, so see how it's all connected? It's like really beautiful. And then, I already talked about this, but like the porousness and the fragility of the blood vessels makes patients more prone to hemorrhaging. So patients start bleeding in tumor spot after coughing. Okay, I already said that. Okay, so, so these are some growth factors that can promote this. We have vascular endothelial growth factor, which promotes the growth of vessels in the endothelial cells, platelet-derived growth factors, which are growth factors that come from platelets, and basic fibroblast growth factors, okay? So number 6, all right, and don't worry guys, there's only 8 of them. Number 6 is reprogramming energy metabolism. So again, normal cells are going to use oxidative phosphorylation to get energy. Cancer cells are going to use aerobic glycolysis, or I think some people recognize it as anaerobic metabolism, okay? This is a condition known as the Warburg effect, which is when cells use glycolysis even though they have oxygen. So if you remember from the cell stress and adaptation lecture that we had with Professor Hagemann, Jesus Christ, what was I saying? I just lost my train of thought. Okay, the lecture we had with Professor Hahnemann. Usually, cells undergo glycolysis in the lack due to lack of oxygen, usually in ischemia or in cases of hypoxia, right? This causes the cells. That's how we get metabolic acidosis, right? That's not good. But in this case, the Warburg effect is when cells do have oxygen, but they choose to undergo glycolysis anyways. And remember what glycolysis does? It produces lactic acid, which makes the environment more acidic. Now, if you do remember, you will know that this process produces 2 ATP, whereas oxidative phosphorylation produces 30 ATP. So you're probably thinking, well, why would a cancer cell want to use glycolysis if it could just use oxidative phosphorylation and get more energy from oxidative phosphorylation? Like, wouldn't it be more efficient to use oxygen instead of using fat? And again, you could tell this to the cancer, but the cancer's gonna be like, fuck you, I wanna do what I wanna do. And guess what it wants to do? It wants to do aerobic glycolysis. Why? Because aerobic glycolysis is much faster than oxidative phosphorylation. Okay, that is like the creme de la creme of everything. That is the reason, all right? Glycolysis is much faster than oxidative phosphorylation, and it also helps the cancer cell withstand hypoxic environments. Okay, and that acid that's being produced by aerobic glycolysis also makes the environment more acidic, which makes it harder for other cells for your white blood cells to come in and kill it. It helps the cells evade immune cells due to the acidic environment. Because remember, your cells are very sensitive; they work best at certain pHs. Okay. If you come into a place that's very acidic with a low pH, your proteins, the minute that macrophage or T lymphocyte comes into that environment, its proteins are going to start denaturing, which is going to lead to the cell dies. So it's not going to be able to kill the cancer. That is why cancer cells prefer aerobic glycolysis. Okay. Number 7 is the resistance to destruction. Again, the cell is not able to kill itself. It is not able to die. So remember our P53 gene, right? This is the gene responsible for detecting DNA damage, stopping a cell cycle, and triggering apoptosis. A mutation to the P53 gene means that you are cooked. Okay. In cancer, your P53 gene becomes mutated, right? And so if it's mutated, it's not going to do any of these things. It's not going to detect the damage to the DNA. It's not going to trigger apoptosis, and it's not going to stop cell cycles. So that's going to lead to division of damaged cells. And when your damaged cells keep dividing, there's a higher chance for you to start one of the pathways of cancer growth. So there's a higher chance you're going to get these factors that we talked about. Okay, that's why I say like all roads keep leading back to Rome. Okay. Okay, so another example is your tumor-associated macrophages, which are your TMs. Okay, so these are not good. Okay, tumor-associated macrophages are not good. They're friends to the tumor. Okay, they're associated with the tumor. And I think these are the M2s, the M2 macrophages, but I could be wrong. That's just me trying to link stuff together, okay? They work by diminishing cytotoxic responses. They block your natural killer cells, and they secrete, so these are your M2s, or mutated versions of your M2s. So they secrete growth factors and angiogenetic factors, which leads to more cancer, yay. And then we have your avoiding immune destruction. So they hide from our immune system and our tumor suppressor genes. That is, ta-da! Except in this case, they're not just hiding from the tumor suppressor genes, they're also hiding from your white blood cells, your macrophages, your lymphocytes. Went a little too far. Your macrophages and your lymphocytes. All these factors help them become resistant to destruction. Okay, they cannot be killed. They will not be killed. The body wants the cell to stop reproducing, but the cancer is like, no, fuck you. I'm going to do what I want to do. And it does what it wants to do, which is it keeps growing. Okay, number 8 is the activating of invasion and metastasis. And this is like, if you see metastasis, that is how you know the cancer is really bad. Okay, I really feel like, and this is really seen in late stage cancer, but it's really hard to come back from this because cancer in the brain, if your cancer starts in your lungs, it's going to go up to the brain. That's going to make it harder to kill. And yeah, like, I don't know. Anyway, I'm thinking of people who have cancer, and I feel sad, okay? So again, this is when the cancer starts spreading to distant sites from its original site, okay? It usually happens through direct extension, right? It goes into nearby tissues, then it penetrates your lymph or your blood vessels, and from there, it's kumbaya, right? It's barbecue chicken. It goes anywhere. Your blood travels to every single part of your body, right? So if a cancer enters the blood vessel, it's barbecue chicken from there. Like, I don't know what you want me to say. Okay, so there's other different ways that, sorry, I lost my train of thought. There's other different ways that cancers can metastasize. One example is known as seeding, which is when the cancer is transported through the lymph or blood and it circulates. The thing is that in the blood, what do we have in the blood? We have a bunch of white blood cells. We have a bunch of macrophages, neutrophils. Most times the cancer will die here. But again, all you need is one cancer to make it. And if that cancer makes it, it's going to go somewhere, attach itself somewhere, and it's going to keep reproducing. Okay, that's why it's not good. The next thing is the transport to secondary sites. So once it enters the blood, most of the cancers are going to lodge in the first capillary bed that they hit. Okay, and I'm gonna come back to this again, like in a few minutes, because I'm about to talk about something else, but I'll get to that when I get there. Okay, and then we have colonization, which is when it goes through extravasation, which it leaves the blood vessel and it enters a new environment and it starts doing angiogenesis in this new environment and thriving. Okay, now think about it. In its original site, that cancer cell created blood vessels. Okay, it angiogenesed. I just made that word up right now. I don't think that's an actual word, but it angiogenesed and it created blood vessels. Then it entered these blood vessels and went to a different capillary bed, and then to a different site, and then it left that blood vessel, and it left the blood vessel, and what did it do? It stayed in this new cell. So what's it going to do in this new cell? It's going to start creating more angiogenesis. So it's going to start creating more of those trashy, weird, porous, and fragile blood cells, which is why cancer patients are prone to bleeding. Because once this cancer starts metastasizing, everywhere it goes, it's going to keep creating these rubbish excuses of a blood vessel, which is going to make people more prone to bleeding. Okay, like I said, it's really, like, the more I think about it, the worse it sounds. Like, you hear about cancer every day, you hear, oh, this person has cancer, that person has cancer, but then when you start learning the mechanisms of it, you realize just how bad or how severe cancer actually is. Okay, but that's just me going off track. So here I said, if it can't equal metastasis, I have no idea what the fuck that means. I don't know what I was thinking when I wrote this. Like, genuinely, I'm trying to understand this, but I don't know what I said here. But I already said everything I need to say. That's like, whatever this is was probably just to emphasize one of the points I already made. Okay, now we're going to talk about the thing that I said I wanted to talk about, which is organ tropism. So if you remember, tropic is movement. Organ is organ. So organ tropism is the movement of a cancer from one place to an organ, or from one organ to another organ. Okay? And here's the thing. cancer cells prefer certain organs because they have growth factors, chemokines, hormones, tissue-selective hormone receptors, and chemotactic factors. Okay, so some of our organs are hubs for all these nutrients and all these chemicals and all these like things, and cancers love these organs. So which organs are these? Well, first we have our brain, our liver, our lungs, and our bones. Okay, those are like the main ones. So think about it as BBLL. So it kind of sounds like BBL, but with an extra L. So brain, bones, liver, lung. So whenever a cancer metastasizes, it's most likely going to end up in one of these 4 places. Now, how do you know which one is going to end up in first? Well, then you have to look at the blood flow, and that's where your knowledge of your cardiac cycle comes into play. Okay, so I have some examples over here. I'll just walk through them with you. Okay, so say you have a cancer that starts in your lungs. Okay, so think about it. When blood leaves your lungs, where does it go? It goes to your pulmonary veins, which carry your blood back into your right atrium. And this right atrium transports the blood into, your left atrium. Wait, huh? Yeah. Your left atrium. Okay, let me start over. Forget what I just said. You have a cancer in your lungs. Okay. Your lungs have a bunch of blood vessels. So the cancer enters the blood vessels of the lungs and it goes into your pulmonary veins because your lungs take your pulmonary veins take oxygenated blood from your lungs back to the heart. So the cancer enters these pulmonary veins, it ends up in the left atrium. It goes down into the left ventricle through the mitral valve. The left ventricle takes this blood and shoots it up into the aorta, your aortic valve, your aortic semilunar valve. Okay? Your aorta branches off into the trunk. I think it's the brachiocephalic trunk, but I could be wrong about that. I haven't really brushed up my anatomy in a while. But if you remember on your aorta, it kind of looks like this. Yeah, so this is like your heart chambers or whatever. I'm not really trying to draw a heart right now. This is so ugly looking. But this is your heart chamber for some reason. And this is your aorta. So the left ventricle takes all this blood and shoots it up through the aorta. Then the aorta has the descending arch and the ascending arch. And it has these blood vessels up here that go straight to the brain. That is why lung cancers are more likely to end up in the brain. Again, brain, bone, liver, lungs. If you have a cancer, it's very likely to metastasize to one of these places. All right. Okay, next we have colorectal cancer. Your rectal is at the bottom. So your veins are going to take that blood from your colon to your liver. Okay, your liver has hepatic portal veins. These hepatic portal veins are going to go up through the inferior vena cava into your right atrium. Okay, let's do this. So your liver, okay, so your colon takes the blood, it gets to your liver, right? The vessels in your colon will meet the vessels in your liver at some point. So the blood develops in the liver. The liver takes this through the hepatic portal veins. It goes back into the your inferior vena cava. Your inferior vena cava takes this into your right atrium. The right atrium shoots it into the right ventricle. The right ventricle shoots it into your pulmonary arteries. Your pulmonary arteries take it to the lungs. And guess what? Your lungs, they love, like cancer loves the lungs. Okay, so now it enters the lung, and now you have lung cancer too. And so you have cancer of your liver and cancer of your lungs. Okay. So again, like it's really all the same thing. Again, it's going to end up in your brain, it's going to end up in your liver, it's going to end up in your lungs. So if you want to, you can really, you could give yourself some examples and try practicing, but it's tracing the blood flow. Most of it is tracing the blood flow, okay? The reason, okay, and if you notice, a lot of this cancer is going through the heart, so you're probably asking, okay, so why don't we get any cancer of the heart? Here's my little box explaining that. The reason we don't see cancer in the heart is because there's so much pressure and there's so much stuff going on in your heart. Also, in a normal heart, this is actually something I'm learning in cardiac right now, but your endocardium is like really smooth, right? And why is it smooth? It's smooth because we don't want any blood clots happening. Because blood clots very easily, okay? All blood needs is one rough surface and it's going to start clotting. So your endocardium is smooth, so there's nothing for the cell to attach to, it's just there. And there's also a lot of pressure in your heart, okay? So there's not even enough time. Your heart beats at about 60 to 100 beats per minute, okay? That's like boom, 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 boom. But the cancer doesn't have enough time to stick to the heart. Is it impossible for a cancer to stick to your heart? No. Does it happen? Rarely, okay? Keep that in the back of your mind. So remember this, BBLL. Of course, there's other places the cancer can metastasize, okay? There's like lymph nodes and their peritoneal cavities, but again, it's more likely to be one of those 4, okay? Bones are bones. I don't know. Okay, now let's talk about inflammation and cancer. So, inflammation is one of the main causes of cancer. Actually, no, let me rephrase that. Chronic inflammation is one of the main causes of cancer. Why? Because inflammation, if you remember from your self-stress and adaptation, inflammation will lead to an increase in your reactive oxygen species, which will lead to an increase of free radicals, which will cause oxidative stress. Oxidative stress will cause your DNA to be damaged. And damaged DNA is free ground for mutation of your genes, which will increase your risk of cancer. Because you need like, again, 4 to 7 hits. Okay? And once your DNA mutates, that sets the cycle. It starts the cycle. So you're more likely to get cancer if you have something causing chronic inflammation. Okay? And okay, so this is like another way to help you reason it, but if your tissue is constantly being inflamed, your cells will keep dividing to combat this, right? Over time, they're going to make a mistake. And the more they keep dividing, the bigger these mistakes get. They accumulate over time. And this will increase your chances of cancer. That is why inflammation is bad. Chronic, mind you, not acute inflammation. Chronic inflammation is bad. Anything that causes you to have chronic inflammation will severely increase your risk of developing cancer. So some examples are chronic hepatitis, which hepato means liver, guys. Hepato means liver. You know this. If you have chronic hepatitis, that means you have chronic inflammation of your livers. This will lead to cell division, which will lead to cancer. I think it starts off as like dysplasia, then it becomes carcinoma in situ, and then it becomes cancer. Helicobacter pylori causes stomach inflammation, which will lead to stomach cancer. Chronic smoking. This is literally textbook example, guys. We've gone over chronic smoking so many times. Damn. Okay, here it is. Chronic smoking leads to your dysplasia, which leads to carcinoma in situ, which leads to cancer. And where is it? Oh, here we are. Okay. All right, and then we have the key takeaway. If you don't remember anything from this section of my notes, just remember that anything that is chronically inflamed can cause cancer because your tissue will constantly be dividing, which will lead to more mistakes being made, and these mistakes are going to be amplified over time, increasing your risk of cancer. Now let's talk about viruses and cancer. The viruses can cause you to develop cancer. Why? Because viruses alter the cell's gene. The reason they do this is because, again, I talked about this in immunity and adaptation. I can find it for you. I'm not going to do a lot of talking, but I'm going to show it to you and you can read. Oh my God, this is 20 pages of notes, bro. Yeah. Let's see. Yeah, here it is. So you can read this, or you can go back and watch the video I made about it. It's a long process. I don't want to go over it. I don't feel like I have the time. But your viruses will alter your cell's DNA to, they hijack your cell's DNA so that they can produce more viruses. So when you get a viral infection, that DNA has become altered. Okay? And sometimes this can activate your oncogenes and or inactivate your tumor suppressor genes or cause chronic inflammation. So whatever it decides to do, if it decides to do one of these or all three of these, that will increase your chances of getting cancer, right? So good examples are your HPV, hepatitis, and your HIV. It's really easy to remember because they all start with H. So if you get a question that's like, select all that apply, which viruses can cause cancer? HPV, HIV, hepatitis C, B, and C. So HPV is something you get in your genitals, right? So you're going to get cancers of your cervix, cancer of your genital regions. Hepatitis is something that affects your lungs. It causes inflammation in your lungs or DNA alteration in your lungs. So you're going to get hepatocellular carcinoma. HIV is like really bad. It affects your whole body. So you can get cancer anywhere. Also, HIV makes you more prone to even more types of infections, which can lead to more inflammation, which is why people who have uncontrolled HIV are likely to develop AIDS, which can lead to the development of opportunistic cancers. That's why HIV is like really bad. That's why HIV used to be really bad. Now we have like different ways of treating it, luckily. So thank God you were born in 2026. Okay, so again, Dr. Hadamon didn't want to say it because he's a teacher, so, or Dr. Ariano didn't want to say it because he's a teacher, and you really have to watch what you say, especially in the school setting in today's society. But I am a YouTuber. I don't really, and plus, I'm the only person who's going to watch this video, so I'm going to just say it anyways. If something increases your chances of getting cancer, and there's a way to stop it, or to stop your chances, or to stop this thing from happening, you're better off doing it, right? Because a lot of people are against vaccines because they think that vaccines cause, I don't know. I don't really understand what's going on with those people. But some people are against vaccines. You probably shouldn't be, because not getting vaccinated can increase your chances of getting cancer. It's also very, very irresponsible because there are people who are unable to get vaccinated because they have health conditions or health problems, and you not being vaccinated puts those people at a risk for developing that disease. So again, you'd be pretty stupid not to get HPV vaccine. Also, again, you don't even want to get HPV, period. So just take it, you know what I mean? Just take it. Like, that's just me. That's my personal belief. I'm highly opinionated, as most people who know me will say. Okay. Another thing we have is bacteria. Bacteria can also cause cancer. Why? Because they lead to inflammation. Your immune system is responding. We talked about inflammation in it's a second line of your defense. So again, if you see bacteria, viruses, you're going to have inflammation. Okay. Again, this causes chronic inflammation. Helicobacter pylori. This happens in your stomach. So you're going to see peptic ulcer diseases, gastric carcinoma. Right. So it's going to cause some cancers associated with your abdomen region. So your stomach, your gastric lining. Okay, now let's talk about epigenetics. I remember I had said something, I'm not going to scroll all the way back, but I had said something about it. I said I was going to explain it. So yeah, let's talk about it. So epigenetics is when you have a change in your gene expression without a change in your DNA. So if I say Peter Penny pickles pepper, oh wait, no, Peter Piper picks, okay, no. If I say she sells seashells by the seashore, think of that as a gene sequence. So epigenetics means that I'm going to change the way I say it without changing what I'm actually saying. So I might say she sells seashells by the seashore. So see how I'm saying something's louder and I'm saying something smaller? That is epigenetics. Some things are being overexpressed while some things are being underexpressed. But at the end of the day, the gene sequence is still the same. So we're not going to have any point mutations. We're not going to have any insertions. Where is it? Yeah, we're not going to have any of these alterations to our DNA. Our DNA is going to stay exactly the same. The only difference is that now some things are being overexpressed and some things are being underexpressed. Now, let me give you some examples of, I have like an analogy for it here. The code stays the same, but the genes are being turned off or on. DNA methylation is a good one. This is one way we could have over underexpression. If a tumor suppressor gene gets hypermethylated, the brakes have failed, right? Because it stops working. It goes silent and it stops. Oh yeah. So if a tumor suppressor gene gets hypermethylated, it gets silent and it stops working. That means your brakes fail. So the gene wasn't mutated, it just wasn't expressed. So it wasn't removed, it wasn't altered, it just wasn't expressed. It's like me saying she sells seashells by the seashore. I didn't say cells. I said it, but I didn't say it. You know what I mean? A good way to treat this is with anti-methylation drugs, which can reverse it. Which can reverse whatever I just did. Okay. Next we have histone modifications. Histones are things that help package DNA. So a change in your histones could lead to your DNA becoming more tightly packed, or it could lead to your DNA becoming more loosely packed, okay? But somehow the gene has been changed, so a change is occurring. If your genes become more tightly packed, they become harder to access, and they become less expressed. If your genes become less packed, they become easier to access, and they become overexpressed. So here, take a second and think about it. What do you not want to be overexpressed? I'm really hoping you said your oncogenes, because I've said that like 1,000 times now. And so think about this one. What do you not want to be underexpressed? And I'm really hoping you said tumor suppressor genes because, again, I've said that like 1,000 times. And then we have number 3, which is microRNAs. So microRNAs are things that regulate your gene expression. So sometimes they can block translation and decrease protein production. So again, this is like some really archaic anatomy knowledge. So your gene leaves the nucleus as RNA. So it gets transcribed into RNA. RNA gets translated into DNA. So if you have microRNAs, they can block the translation, which will lead to some genes not being translated fully, whereas some genes are over-translated. Okay, so that's just that. Again, these are just some examples. There's like way more than just 3, but the key takeaway from this, from cancer epigenetics, is that you don't need mutation to get cancer. Okay, your gene does not always have to be altered. Sometimes they just have to be over or underexpressed. Okay, and what can cause this to happen? Well, nutrition, what you eat, environment, where you live, lifestyle, how you live. Do you exercise? Do you take care of your body? Are you eating the right nutrients? Do you work all the time? Are you constantly stressed? Right? Those can also affect cancer. And this is gonna be going on a tangent, but I love going on tangents, so let's keep doing it. But one of the reasons that people stopped early screening for cancer was because if I screen you for cancer and I tell you that you have a 50 or 60% chance of developing cancer by the age of 40, right? What are you gonna do? You're gonna start stressing out about it. Now, is there anything I can do for you? Probably not. Probably not. I can just tell you, like, hey, by the way, there's like a 50 to 60% chance you're gonna get cancer by the time you're 45. And you're gonna be like, what the fuck? Are you serious? Is there anything I can do to stop this? And I'm gonna be like, no, not really. I just wanted you to know that. So like, now this person is going to live their life scared of the day they turn 45 because they know that once they turn 45, they're gonna get cancer. Even though, again, I said 50 to 60% chance. This does not mean 100% chance. But you know how people are. If I tell you have a 50 to 60% chance of developing cancer, you're gonna be like, oh my god, I'm gonna die. Even though I say you have a 50 to 60. So again, that's why people stop screening for cancer. Because again, you're just gonna make people worry. And if people worry, what's gonna happen? You're going to see a decrease in the quality of their lifestyle. because now they're going to stop caring about their health. They're going to, oh, I'm going to die anyways. I might as well eat all the burgers I want. Or they're going to start being so stressed that they're now producing all this cortisol. Remember we talked about general adaptation syndrome. I'm not going to go back to that. That's in another video somewhere, or it's in your notes, or it's in a textbook. But in cases of stress, your body becomes you start producing cortisol and catecholamines and glucocorticoids and whatnot, and this will suppress your immune system. It will lead to prolonged inflammation. That could also increase the chances that you have causing cancer, which is why we don't screen for cancer anymore. Except you have like a high chance, like say your mother has breast cancer, your grandmother has breast cancer, your aunties have breast cancer, then they'd screen you. But if you're just a normal person going about your life, chances are you're not going to get screened anytime soon. Okay? Again, one mutated cell is not going to cause cancer. It takes more than one hit to your DNA to cause cancer. Now, if you have one hit to your DNA, the chances of another hit occurring are high, right? Because if smoking caused you to develop activation of your oncogenes, there's a good chance that smoking can also lead to the suppression of your tumor suppressor genes. So that's what I can say when I say all it takes is one to start the cycle. But one mutated cell is not going to cause cancer, okay? However, the events in your early life can later influence your susceptibility to cancer. So say you smoke a lot, or you drink a lot, or you have androgynous hormones, so you're over-secreting testosterone, or say you're a bodybuilder and you want to be buff like really quickly, so you go start taking steroids, right? These things can increase your chances of getting cancer, right? Because they can accelerate your cell proliferation or the deactivation of tumor suppressor genes, okay? Oh yeah, so this is alcohol. And the only reason I added this is because I was when I was writing, I looked at my notes and I was like, damn, I haven't had any like cute little drawings in a while. Like it's just been a bunch of writing. Oh, close that by accident. So I then added like this little diagram. So with like my notes, because I love when my notes have like little people or little cartoons and whatnot. So this is basically alcohol, and the alcohol is telling the cancer cells to grow, right? And then this is your tumor suppressor gene, and who usually tells the cancer cells like, hey, stop growing. So the alcohol is like, don't tell my babies what to do to the tumor suppressor gene. Okay. Of course, this is all happening through chemical or metabolic pathways. It's not like actually talking to the cancers, but I don't know. It just feels funny. Okay, so let's move on. Let's talk about cancer in your utero and early life conditions. This actually ties into something I've already how much do I have left to go over? Oh, okay, we're almost done. So let's talk about cancer in your utero and early life conditions. So your risk for cancer can start before you are even born, okay? And your early life exposures can influence your future susceptibility to cancer. So if you're a baby and your mother's not eating well, or she's doing drugs, or she's living in a toxic environment, say she lives like in a place with a lot of radioactivity, or a place where there's like a power plant nearby and they're like destroying the environment and she just happens to live there, there's a good chance that both her and you in the womb can develop cancer. Again, before you are even born, right, before you even become conceived, before your parents do the deed to produce the being that is you, if your parents were exposed to toxins that altered their germ cells, you can also have like a genetic chance of getting cancer. Okay? Does this need explanation? No, but it does need clarification. Okay, so this only happens if it affects their germ cells. Okay? Not the other cells, the germ cells, which is the cells that will reproduce to develop you. If she gets it in her breast and that breast cancer stays in the breast and it does not get to her ovaries, it's not going to affect you. If your dad gets it in his lungs due to smoking and it stays in his lungs, it doesn't get to his germ cells, his sperm cells, it's not going to affect you. Okay, this is what I mean when I say cancer is not contagious. But it is. It is genetic. So an alteration to your mom or your dad's germ cell DNA will cause you to have a way bigger genetic increase of getting cancer. Okay, you can also get toxins from breast milk, but this is toxins, not cancer. You can get toxins from breast milk. You cannot get cancer from drinking your mother's breast milk, okay? All right, let's talk about something called developmental plasticity. And developmental plasticity is when the body's development adapts to its environment. And gene expression patterns can change over time due to unhealthy environments. Okay, so that was just a bunch of fancy words for saying when something happens, you're going to adapt. We had a whole chapter on self-stress and adaptation. And like, I'm really glad they made us learn that first, because it really it makes learning everything else interesting. Because there are things that I had just memorized for memorization's sake, and now I'm starting to understand the pathways behind it, and that's really cool. I sound like such a nerd. Anyway, so developmental plasticity is when your body adapts to something, a change in the environment. Okay, usually, if you have an unhealthy environment, you can have unhealthy adaptation, which will lead to alterations in your gene expression, and altering your DNA can lead to what will lead to your hallmarks of cancer: activation of your oncogenes, suppression or the turning off of your tumor suppressor genes, the lack of apoptosis, all those things. Okay. Now, if you want to reduce your risk of getting cancer, the first thing you should do is avoid things that will give you chronic inflammation. If you drink a lot, you're going to get hepatitis. You're going to get cirrhosis. Okay. This will cause your livers to be heavily inflamed, chronically inflamed, which will increase your chances of getting liver cancer. If you smoke a lot, you're going to get bronchitis, COPD. This can increase your chances of getting cancer because of chronic inflammation. If you have unprotected sex a lot, you can develop HIV, you can develop HPV. This will increase your chances of getting cancer. Okay, so you really want to prevent stuff that causes chronic inflammation. You also want to avoid sun exposure. Why? Because UV rays act on your epithelial cells. This causes your epithelial cells to start randomly dividing to heal the sunburns from the UV exposure. This dividing becomes chronic if you are constantly being exposed to the sun, and chronic inflammation will lead to cancer, or can lead to cancer. It won't always lead to cancer, but it can lead to cancer. That is why people are always saying avoid tanning, avoid UV radiation, wear sunscreen, because skin cancer is the most common type of cancer because people are always in the sun. Their epithelial cells constantly need to be dividing. I remember what I said: if something keeps having to divide, the chances of it making a mistake are much, much bigger. Right? And if it makes a mistake and it keeps dividing, the chances of that mistake being proliferated, being overexpressed, are again much higher. These things contribute to cancer. That is why skin cancer, melanoma, carcinoma, basal cell carcinoma, squamous cell carcinoma, these are like the most common types of cancer because you're constantly being exposed to the sun. Again, you want to exercise and you want to watch your diet. I feel like those are self-explanatory. Okay, so let's talk about environmental factors. First things first, we have ionizing radiation. Exposure to radiation, which could be from X-rays or other radioactive sources, can cause cell death, or gene mutation and chromosome aberrations, which is just alterations to your chromosomes. They could be either through insertions or deletions or point mutations or whatever, but something is changing somewhere that should not be changing. And I kind of already explained that. Again, radiation, not good, causes your cells to keep dividing. That's not good. Oh, here, ultraviolet rays causes basal cell carcinoma, squamous cell carcinoma, and melanoma. It promotes skin inflammation and release. Okay, I already talked about this. Yeah, I already talked about that. Okay, alcohol. Damn, I really, not me explaining a whole thing without even knowing what was, okay, look at me eating, so you can read it. This is tobacco. Avoid e-cigarettes and vaping. Again, you want to exercise. This is why. I'm gonna just hold it so you can read it. Okay. Then sexual reproductive behavior. Yeah, and then where you work. This one I don't really have any explanation for it because it's pretty obvious. If you work in a radioactive plant, you're exposed to radioactive chemicals which will alter your DNA. And it will not give you superpowers. It will cause you to become very sick and you most likely will develop cancer. Okay, and then what you eat. So we have something called xenobiotics, which are toxic mutagenic chemicals in your food. And examples of this are foods used in cooking fat, so your oils, your meat or proteins, your mold, alkalosis. Yeah, so what you eat can also affect your chances of getting cancer. And then you have obesity. Why? Because obesity increases the circulating hormones in your body. And anything that has to do with hormones, just knows your body is going to be reacting to them because hormones are very, 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 very strong. Okay? So that's also why you want to exercise. I don't know if you read it, when I paused you read it, but because you're going to decrease the amount of insulin circulating around in your body, which will increase the alterations to your cells. So yeah, that is that. What else do you want to do? Okay, so those are that. I already talked about most of this. Yeah. Okay, let's talk about clinical manifestations of cancer. Ooh, oh my God, it's like, okay, so we already know what can cause cancer. We know how it comes to be. Now let's talk about how it looks like to us, the healthcare professionals. What it looks like to nurses, what it looks like to doctors, the physicians, how it's going to look like in a clinical setting. But before that, we have to talk about something known as a paraneoplastic syndrome. So this is, okay, again, let's go through it. Para means next to or adjacent. Neoplastic is cancer, and then syndrome is a collection of signs and symptoms, okay? Paraneoplastic syndrome, just from the definition, just from the word, right, just from like the meaning of a word, you can tell that it means something that is adjacent to cancer, causing a collection of signs and symptoms. Okay. Now let's look at the definition. This is like a syndrome caused by substances released by the tumor and not the tumor itself. Okay. When cancer divides or when cancer reproduces, when cancer rapidly reproduces, it's going to release a bunch of chemicals, and these chemicals cause problems. These problems, it's going to release chemicals. So these are the chemicals. It's like I release chemicals that cause problems, and these are the chemicals, and look at them, they're going to cause problems. So again, the important thing about paraneoplastic syndrome is that it does not come from the cancer itself, right? So it's not caused by pressure or obstruction or direct invasion. It is caused by the chemicals released by the cancer, so hormones, cytokines, immune reactions. The cancer itself does not cause paraneoplastic syndrome. If the cancer caused it, it would be neoplastic syndrome, not paraneoplastic syndrome. And I'm just saying that like English-wise. Okay, I don't actually know if neoplastic syndrome is a thing. I'm just giving you like how that would present itself. Okay, so let's talk about some examples. If a cancer releases ACTH, which is adrenocorticotropic hormone, or ACTH-like substances, what's going to happen? So a cancer of your adrenal gland is going to release adrenocorticotropic hormones. Adrenocorticotropic hormones is going to cause Cushing syndrome. What is Cushing syndrome? I don't know. I definitely say you should look it up. I don't want to look it up right now. Okay. So if you had cancer to your kidneys or something, we're going to see the release of antidiuretic hormones or atrial natriuretic peptides. This will cause inappropriate ADH secretion, which will lead to water retention. I guess that could cause edema. Yeah, I'm just thinking out loud, okay? And then we have insulin or insulin-like substances. And so if a cancer starts releasing a bunch of insulin, which could be like if you have lipoma, which is fat cells or something, I don't know. But if they start releasing insulin, you're going to have hypoglycemia. If it releases serotonin, bradykinin, you're going to have carcinoid syndrome. If it releases erythropoietin, you're going to have polycythemia. You don't really need to memorize this, but it's good if you understand it, right? So what's the big takeaway from paraneoplastic syndrome? It is not caused by the cancer. It is caused by the chemicals that the cancer releases. Okay? If you don't remember anything about that, just remember, para means adjacent to or next to. Neoplastic is cancer, and syndrome is a collection of signs and symptoms. So paraneoplastic syndrome is a collection of signs and symptoms associated with something that is adjacent to cancer, aka the chemicals that it releases. All right, so let's talk about another clinical manifestation of cancer, which is pain and fatigue. So pain. In the early stages of malignant cancer, we're not going to see a bunch of pain. Why? Because it's the early stages. Okay, you might see your usual fatigue, malaise, anorexia, which are the prodromal signs of illness. They don't mean anything. They can mean anything and everything. Okay, fatigue, malaise, and anorexia can mean a simple flu, or it can mean literal cancer. Okay, so you never know with that. They just tell you that something's wrong. Most people don't even go to the hospital because of this. Okay. Again, this is pain caused by the cancer itself. This is not paraneoplastic syndrome. This is pain caused by the cancer, right? So it's usually caused by pressure. Like the cancer is going to grow. It's going to start exerting pressure on its nearby tissues and organs. That's going to make you feel sensitive, right? It's going to make you sore, tender in those places. This is also pain. The pain can also be caused by when the cancer invades sensitive structures or it stretches your visceral surfaces. If you have cancer in your lungs, it's going to start making that part of your lungs grow bigger. So that pressure that's being exerted on the lungs, on the surface, is going to cause pain. That's how you get pain from cancer. And then fatigue, right? So it is the most frequently reported symptom of cancer. Like when a cancer patient first goes into the hospital, the first thing you're going to say is like, I just feel really tired. And here's the thing. Feeling tired could mean anything, right? But the difference is, when I feel tired, I don't book a doctor's appointment. I watch Bridgerton, right? When some people feel tired, they bake. Like one of my friends, she literally baked me like a muffin because she was stressed out. Like she was like, hey, I made you a muffin because I was stressed out. And I was like, oh, thank you. The thing, see, it's like when you're tired, some people, they take a nap. Some people book a trip to a different part of the world. Most people, when they are tired, are not going to book a doctor's appointment, okay? So if you have someone who books a doctor's appointment solely because they feel tired, this should indicate to you as a professional, as a healthcare professional, that something is wrong somewhere. Okay, if someone comes into the hospital or someone comes into a clinic and they say, like, I just feel really, really tired, you do not send this person home. Because for them to take the stress to book the appointment, to come in, to spend all this money and insurance to do this means that it is clearly not a normal type of tiredness. Keep that at the back of your mind. Okay, next we have cachexia, which is muscle wasting. It is the most severe form of malnutrition, and it is present in 80% of cancer patients at death's door. Okay, this means you're in your late stages of life. So what do you see with cachexia, which is muscle wasting? Some people say cachexia. I don't care how you want to pronounce it. That's up to you. I'm not known for my stellar pronunciation. Okay, guys. All right. So what do you have? You have anorexia. You have weight loss, anemia, altered protein. People with cachexia literally look like a stick. Oop, that's a highlighter. They literally look like this. See how skinny they are? A normal person is probably gonna look like this. This is literally what people with. Like, I'm not making fun of them. Like I'm just giving you an example. And I don't want to take my time to really draw this. I don't know why I decided to make it a girl for some reason. And she has a little beard representation. Okay, let me give him like an afro. Black History Month. No, he has cachexia, so he's not smiling about that. Okay. Okay. So again, we're going to see all these things: altered protein panel, altered lipid panels. We're going to see something called asthenia, which sounds so magical. Like it sounds like a kingdom in Lolly Rock. Those who know. If you don't know, then you don't know. If you don't know, you don't know. Generalized, but just, and asthenia basically means generalized physical weakness. It's just you being weak. Okay. So with asthenia, the patient, with cachexia, the patient is entering their end stages of life. You see this in people who are there's really no coming back from it. So at this point, they're in hospice. Okay, that's why you see people with cachexia. Why? That's because this cancer has fully metastasized. It has grown. It has stolen. It has killed, and it has destroyed. Okay, it has told the body to fuck itself, and fuck itself it did. Okay, so this cancer is taking all the nutrients that this person has. So the muscles are being broken down through glycolysis to create energy for this cancer. This person, obviously, they have cancer, so they're not going to be eating enough. They're not going to feel the need to eat enough. So they are malnutrition. And even though they're in the hospital, they might be on drips and everything, but it doesn't compare to real food. Right? And even if they are on drips that are compared to real food and they are really good, like alternatives to food, they might not be able to tolerate it because depending on where this cancer is, their digestive system is not going to be working the way it should. Their urinary system, excretory system is not going to be working the way it should. So that's why you see cachexia, because it's really sad. There's even a condition called failure to thrive. This is a real thing, by the way, failure to thrive. So this person is literally failing to live. Okay, the tumor is taking over their body. It's taking over their life. Cancer is like really sad, guys. Anyways, not anyways, but like moving on. Tumor markers. So a tumor marker is a substance released by benign or malignant cells. So it could be found on or in the tumor. So say this was a tumor is cancer, or cancerous tumor. And so this is a tumor marker. It could be found in the blood. There's your tumor marker. It could be found in your spinal fluid. There's your tumor marker. It could be found in your urine. There's your tumor marker. And so a tumor marker is just anything that indicates that a cell is rapidly reproducing uncontrollably, okay? Or it's reproducing uncontrollably. Like it should not be reproducing, but it is reproducing. So what are we going to see? Hormones, enzymes, genes, antigens, antibodies. Okay, now you're not going to see all of this, but you might see 1 or 2 or 3. You might see all in a person who has late stage cancer, maybe. But these are like examples of what I say when I say, oh, this person has a tumor marker. This is what I'm referring to. And again, it makes sense. Okay, think about it. If you have cancer of your adrenal gland, right? So that means the cells in your adrenal gland are rapidly reproducing. And what does your adrenal gland do? It secretes cortisol, epinephrine. Okay, so in a person who has cancer of the adrenal gland, you're going to see a crazy amount of epinephrine in the blood that should not be there. Obviously, if you have epinephrine in the blood, then it's probably going to act on your alpha and beta receptors to cause vasoconstriction, increase blood pressure. That's just me ranting off like everything I know, but that's besides the point. This person has so epinephrine is a hormone. So in a person with adrenal cancer, you're going to see a bunch of epinephrine. Again, like that's what I mean when I say a tumor marker. It's just a chemical that the tumor produces that tells you that, oh, there's a cell here that is growing that should not be growing, or it's growing, but it's not growing according to the body's standards. Okay. So examples. Oh, I have examples here. Oh, look at that. Liver and germ cells, right? Cancer of your liver or cancer of your germ cells will secrete alpha-fetoprotein into the blood. Okay, which is why if you bring in someone and they have an issue and you take a blood test to see if it's a bacterial infection or if it's whatever, you're looking for a white blood cell count or something, and you notice that this person has alpha-fetoproteins in their blood, that signifies to you that this person either has a cancer of the liver or has a tumor of the liver, or this person has something going on with their liver or something going on with their germ cells. Okay, and then another example is your prostate cells, which secrete something known as prostate-specific antigens into the blood. So again, someone comes in and they feel sick, you take a blood sample, you test it, and you realize this person has prostate-specific antigens in their blood. This is an indicator that this person may be developing cancer of the prostate, okay, or developing a tumor in the prostate, okay? So fun fact, there's nothing fun about this, but I don't know, I just called it a fun fact because I didn't know what else to call it. But if a tumor marker itself has biologic activity that can express symptoms, this leads to a phenomenon known as paraneoplastic syndrome. Remember, these are substances caused by the tumor. These are syndromes caused by substances released by the tumor and not the tumor itself. So this substance released by the tumor is a tumor marker. And literally, what a tumor marker will tell you is that a cell is reproducing. And this substance is something that usually happens when that cell is reproducing uncontrollably, okay? It's a bunch of big words, but essentially it's like a really simple concept, okay? Okay, so what do we use a tumor marker for? We use them to identify and screen individuals at high risk for cancer. We use them to diagnose specific tumors, and we use them to observe the clinical course of cancer. I'm going to explain that, but I want to say something. Just because someone comes into the hospital and you test their blood and you realize that they have alpha-fetoprotein does not mean they have liver and germ cell cancer. Okay, I know it sounds contradictory, but like, stay with me here. Stay with me, okay? Your liver cells produce alpha-fetoprotein. Okay, so remember how I said there's a difference between something being benign and something being malignant, right? So tumors can be benign and malignant. Cancers are only malignant. So if something is benign, that means it is reproducing, right? It's reproducing and it should not be reproducing. But this reproduction is not causing any, what's the word I'm looking for? This reproduction is not causing any crazy effects right now. Like I said, something can become, something that's benign can become malignant, but we're not talking about that right now. But if you have a benign tumor, like for example, in patients with benign prostatic hypertrophy, which is something we're learning about in some of our other classes, people with this, you are going to see them secrete prostate-specific antigens, right? Because again, it is growing, and when it grows, it secretes this antigen, right? But that doesn't necessarily mean that this person has a cancer of the prostate. It means they just have a benign prostatic hypertrophy. You see what I mean? So just because someone has a tumor cell, a tumor marker is not a direct indication that this person has cancer. It literally just means that so it can help you screen for cancer, which is what this first point is. You can identify and screen individuals for cancer. So if someone comes in and you notice that they have PSA in their blood, that's a sign to tell you, hey, this person might have cancer. It's not a guarantee that they have cancer. They might have cancer. So this is basically going to tell you that you need to run a couple more tests. Okay? That's the first thing. The second one was it helps us diagnose specific tumors. Again, if you see PSA in the blood, your first thought is going to be the prostate. So what are you going to screen for? You're going to screen for prostate cancer. And there's a good chance this person will have prostate cancer. There's also a chance that they might have benign prostatic hypertrophy, which is why we screen. So when you screen, so these tumor markers, they tell you where to look. Okay, they tell you, look here, look there. And remember how I said organ tropism, right? So it starts in the prostate, it can lead to the liver. Where is it? Oh my, it's like a, damn, keeps going. I know I talked about it in organ tropism. All right, let's zoom out a bit, see where we are. Oh, here we are. So it starts in the prostate, it goes to the bone. From the bone, it can enter the liver, it can enter the lung. It could also skip the bone and go straight to the liver and the lung. Like I said, these places, cancer loves these places, so it doesn't really care which one. And again, this is just a likely pathway. This won't always happen. Like a cancer of the lungs won't always metastasize to the brain. Okay, the chances of it metastasizing to the brain are really high though, but like it won't always happen. And again, this is where those tumor markers come into play, right? So your lungs secrete what do lungs secrete? I don't know. But lungs secrete chemicals that are specific to the lungs. So if someone comes in with a seizure and then you check their brain, you get a biopsy of their brain, and a biopsy is a procedure where you cut out a piece of it and you scan it, or you look at it under a microscope, you might see a chemical that is significant or it is synonymous with the lungs. And that's how you know that this cancer has come from the lungs. Okay, so that's what tumor markers do. I don't know if I helped you understand that or not. I hope I did. Okay, so that's how you diagnose specific tumors. And then the third thing is that it helps you observe the clinical course of cancer. So say someone comes in and let's make up a fake number because I don't know. So they secrete alpha fetoprotein and you find out that there's AFP in their blood. Now the normal range for AFP in the blood is say 10 to 20, right? Which is also the therapeutic range for digoxin and vancomycin. I just felt like saying that. Sorry, not digoxin, for theophylline and vancomycin. So AFP, right? So say the normal range for AFP in the blood is 10 to 20, and this person has like 1,000. Obviously, they have cancer, right? Like again, you never really know until you run the test. But this is like obviously, if someone has 1,000 when the average is 10 to 20, this person obviously has cancer. And if they don't have cancer, well then they have something else. It's like really bad. So you check it's 10, they have 1,000, the range is 10 to 20. You're like, oh shit, this person has cancer. You send them to get their lungs, a biopsy of their liver, not their lungs, a biopsy of their liver. You find out they have liver cancer. You're like, oh shit, you have liver cancer. Let's start you on some chemotherapy. You start this patient on chemotherapy. A month passes, and you take the blood sample again, and now you have 500. AFP in the blood. Does that mean that the chemo is working or not working? It's working, exactly. So that is how we use tumor markers to observe the clinical course of cancer. Now there's another end of the spectrum. What if this person had 1,000, you did the test, you started them on chemo, they come back and they have 1,500. What is this telling you? It's telling you that this chemo is not working. So now you have to switch to a different method. Okay, that is one of the many ways in which cancer specialists will measure the clinical course of cancer to determine what treatment works versus what doesn't. Okay, let's see, what else did I... Okay, I already talked about that. Okay, let's talk about the stages of cancer. Okay, we have stage 1, where the cancer is confined to its organ of origin, right? So as I was born in the liver, I stay in the liver, okay? Stage 2 is the cancer has become locally invasive. So it's like, okay, I mean, I know I was born in the liver, but like, what if I just, enter the lungs for a little bit? Like, what if I just, not the lungs, right? So say it starts off in the right part of the liver. It's like, okay, well, this left part of the liver looks a little good, right? Like this, it's surrounding. So it enters the nearby tissue, nearby. Stage 3 is the cancer starts entering regional structures. Okay, so a stage 3 would be like the cancer moving from the right lung to the left lung. Okay, so it starts entering lymph nodes, adjacent tissues, and adjacent organs. so here's my cancer cell. So the key difference is that in stage 2, it moves from for example, the upper lobe of the lung to the middle lobe. That is a stage 2. A stage 3 is like it starts entering regional structures or other nearby organs. But the most important thing is lymph nodes. Once it enters your lymph nodes, it is a stage 3. And then we have stage 4, which is where that's where metastasis happens, right? So it's like silly me, I started in the lungs, now I'm in the brain. So there you go. There's your stages of cancer. Again, this is like how the noobs stage cancer. Pros use a different method called the TNM. So the T stands for tumor, N stands for nodes, and M stands for metastasis. So again, T1 to T4 is the range, right? So how big is it? With T1 being small and T4 being astronomically large. Okay, and T0 means that you don't see anything, right? There's no evidence of a tumor. And TX means that you can't measure it. Like it's too big to be measured. It's in too many places. TX is like really bad. Then we have nodes. Again, these are the this basically is asking, are the regional nodes involved? Are your lymph nodes involved? So we have N1 to N4, with N1 being one lymph node or two lymph nodes, with N4 being a bunch of lymph nodes. Again, you have N0, which means that no lymph nodes are involved, and then we have NX, which means that they don't have any information. They don't have the tools to measure it, or they don't have the time to measure it, so there's just no information about that. Then we have metastasis, and this one is actually different. So in metastasis, there's no M1 to M4. There's only M1. Why? Because once you have metastasis, you have metastasis. There's no such thing as a small amount of metastasis. Metastasis is metastasis, okay? So you have M1, which means yes, there is metastasis, and then we have M0, which means no, there is metastasis. And then we have MX, which means we can't measure the amount of metastasis because they don't have the amount of tools. So the thing about this, you don't really need to understand the nuances that go into this. You just need to know that if something is T4, N4, M1, that's like really bad, okay? And if something is T0, N0, M0, that's like really good, okay? Next we have how do you treat cancer. Again, he said this is a patho class, not a treatment class, so it would be good to know how it works. So again, we have chemotherapy. This is what we started with, so it's like a full circle moment. It is the use of non-selective cytotoxic drugs that inhibit cell growth of both malignant and normal cells. And so chemotherapy basically stops the rapid proliferation of cells. They target rapidly producing cells. So there's 4 goals of chemo. We have induction, which is to shrink the tumor. Then we have adjuvant, which is usually given after surgery to kill micrometastasis. We have neoadjuvant, which is given before surgery to shrink the tumor to preserve tissue. And we have salvage. So again, when you're salvaging something, it's already ruined and you can't fix it, but you're trying to. So this is just to control metastasis or to slow down the growth. It does not stop it, okay? So you can either induce or induct a tumor. You can use adjuvant to give it after surgery. You can give it before surgery. And then you can try to salvage it. So those are the goals of chemo. But the main goal is to kill enough tumor cells so that our immune system can work on killing the rest. Next, we have surgery. Now, of course, this isn't always going to work. Like, if someone has cancer of the brain, you can't just take out their brain, right? I mean, okay, well, I guess that's not a good example because you could technically take out a piece of the brain. So if someone has cancer of the lungs, yeah, that's a good example. You can't take out their lungs. You also, I've never ever heard of lung replacement. So, yeah. So there are some cases where surgery is not going to be able to happen, okay? But it's usually, so here we go. It is usually used when cancer has not spread beyond what can be surgically removed. So if it has not metastasized yet, then you can use surgery. If you've got like a small cancer in your liver, you can cut off that piece of the liver, okay? It is the definitive treatment for local tumors. Like the easiest way to get rid of something is to cut it out, cut it off. That's why it's the first treatment for local tumors. So think about the risks involved with surgery, right? You could cause complications, hemorrhaging. You could introduce new infections to that site by opening it up to the environment. There's different types of surgical uses to get rid of cancer. The first one is curative surgery, which is when you remove the entire tumor and you must have clear margins. So, this is a tumor. This is this thing over here. This red part is a tumor. The green part is a part of the cell. So when a surgeon cuts out the tumor, there is an oncologist nearby with a microscope. So they cut it out and they give it to the oncologist. When they give it to the oncologist, he needs to make sure that the cells surrounding the tumor are clear. This indicates that all the tumor has been removed, right? So if he gets that sample and he realizes that this is what it looks like, there's no green borders. That means that they only cut out a piece of the cancer. Okay, so that might have been a little confusing. So let me break it down. So say this is a cell or this is an organ, like your liver. Okay, so this is your liver, and you have cancer here. Oh, it disappeared. Okay, I have to redraw it then. Okay, so you have cancer here. When the surgeon cuts it out, he wants to cut it out like this. Okay, that is what he wants to do. Well, obviously maybe not that big. Maybe more accurate would be, that's too big. Maybe it'd be more accurate to be like this. Okay, so when you take it out, ooh, look at it behind there. Let me know. So when you take it out, you should see clear borders. The oncologist should see clear borders on the thing. So if he didn't cut it out properly, right? If he didn't cut it out properly, when he takes it out, it's going to look like. So say he only cut out a piece of the cancer. He didn't get the whole thing. Oh my god. Damn. Okay, so let's say he did. No. So let's say he did this. This is what he cut out. So when he takes it out and he gives it to the oncologist is going to be like, oh wait, he doesn't have clear margins on this side because this cancer wasn't removed. Okay, so that's what they mean by having clear margins. And the next thing is the next type of surgical use in cancer wise, or you know what I mean, is biopsy. Right. So this is usually to confirm a diagnosis and to stage cancer. So it's basically to tell just how bad the cancer is and to confirm that it actually is cancer. And then we have something called debulking surgery, which is when you remove as much of the tumor as possible. And we usually do this when it's not possible to remove the full tumor. Okay. Okay. So like if you had cancer of your lungs, okay, debulking surgery would be to take out a massive part of your lungs and leave some of it there. Because obviously you can't take out the whole lung, right? This is just an example. I don't know if this is something that actually happens or not. Obviously you can't take out the whole lung. So you're going to remove a little piece of it. And yeah, it's kumbaya. Damn, what else was I going to say? So it's basically going to help slow down the growth or stop it from getting worser. Because it's going to keep getting worse. But this is to stop it or like to slow it down. And then we have 4, which is palliative cancer. So this is when you take it out, not to cure the cancer or to get rid of it, but to relieve some of the symptoms of the cancer to improve the patient's quality of life. So if a patient has a tumor that's like pressing on their bladder, you could cut out a piece of the tumor so that it's no longer pressing on their bladder. That's an example of palliative. You're not improving it. You're just reducing some of the symptoms. So when you're performing surgery, you want to be sure of a few things. Number 1, you must achieve adequate surgical margins. Remember, adequate margins means that you got everything. If it's like this, that means there's still some cancer left. Okay, so the surgeon has to now go back and recut it and then give it to the oncologist to check. Number 2, you should avoid spreading cancer during the surgery. Again, you're working with tools, you're working with chemicals. This is why it's done in a sterile field, guys. So if I have a knife, right? Oh my god, that's way too big. So now this knife, if I use it to cut out the cancer, now this knife has cancer on it, right? So if I use it in a different place, it's going to spread that cancer to that place. So you want to avoid doing that in surgery because you don't want to spread the cancer and make it worse, right? You want to help it. Number 3, you must obtain adequate tissue specimens to confirm the diagnosis. That's self-explanatory. And then number 4 is remove the contaminated biopsy tracts. This ties back into this. Yeah, it's literally the same thing. You want to remove anything that might have come into contact with the cancer that's in the body because you don't want it to spread. Okay, and then we talk about immunotherapy, which is like the main one. So the purpose of immunotherapy is to help our immune cells attack the cancer. The thing is, we have cancerous cells in our bodies every day. The only difference between us and the people at the hospital is that our cells are successful at killing them off before they become worse. Okay, so our immune system already knows how to kill abnormal cells. The cancer is just good at hiding. So immune therapy works to remove that hiding. So a good example of this is the checkpoints. Usually we have checkpoints in our body that stops us from. Again, I mentioned this in the immunity chapter. You can go rewatch the video. It'll be like a minute. I just don't want to go over it again. But usually there's stuff. I don't remember what the word is, but there's stuff on the cell membrane that tells other cells that I'm a normal cell. Don't kill me. In cases with people with autoimmune disorders, that pathway doesn't work. So our immune cells kills those normal cells, and that leads to an autoimmune disorder. Again, I talked about this before, but I'm just doing a quick recap so it makes sense. But again, we have things that say, hey, I'm a normal cell. Don't kill me. Okay? Cancer also has this thing. So it tells the T cells that, hey, I'm a normal cell too, so don't kill me. And the T cell's like, okay, I believe you, and it goes away, and the cancer is free to keep doing what it does. So for one example of immunotherapy is that we have checkpoint inhibitors. So they remove this checkpoint. So even though the cancer is like, hey, I'm a normal cell, don't kill me. The tumor cell's like, yeah, I don't give a fuck, and it kills it anyway. Okay? But think about it. If you remove a checkpoint inhibitor, that means that even the normal cells, like the actually normal cells, are also going to be killed by the T cells. So this is going to affect us too. It can lead to all sorts of other cases, but right, anything is better than cancer, right? Okay, so then we have BMRs, which are biological response modifiers, which boost our immune activity. We have monoclonal antibodies, which are lab-made and target specific proteins on cancer cells. Again, this was all in the immunity chapter, so you know how antibodies work. I don't need to explain it to you. And then we have CAR T cells, and these remove T cells. So this works by removing T cells, training them, and putting them back into the blood so that they can go in and kill the cancer, because now they have been trained to recognize your cancer cells. This is very effective because it's very specific, right? But also, it's very expensive. So yeah, that's the end of cancer.